name is Brandy Singfield. I am an anesthesiologist by practice, but I'm the current digital health fellow here for Medicine X. I get a lot of my training through the Anesthesia Informatics Media Lab, which is central to making Medicine X happen every year. So I'm going to be moderating this afternoon session. One of the key elements in all of the things that I hope that you're learning is that answering patients' problems by engaging them in their care is going to be crucial to transforming healthcare. And so we have four very different perspectives that all intersect with trying to answer this problem with engaging patients in healthcare. So they will have an opportunity to tell their story, and we will take a few questions after, and then afterwards we'll have all the panelists come up and we'll provide an opportunity to answer more questions. But just for the sake of time, we'll keep the questions to just a few right after they talk, and then we'll have them all come up at the end. Okay. And with that, we will introduce Amy Gleason. Amy Gleason, she has found a unique path for herself. She has encompassed her work as a registered nurse, as well as a passion for technology, as well as a caregiver for her daughter. She is currently the Chief Operating Officer at CareSync, a company that I think she'll give a lot more depth knowledge on what they do and how they answer the question of patient engagement and how patients and caregivers can be involved in their own care.
So it's hard to do things if you don't remember what you're supposed to be doing. So I'm going to talk today about what I think are the four main barriers to patient engagement and the ways to resolve them. So the first one is access to information. So the first thing is patients just need access to their own information, and not just bits and pieces of it, but all of it. So I'm not sure if you've ever tried to get your medical records from somewhere, but it's actually a pretty difficult process. There are all these different forms to fill out, and they're all different. So every different doctor, every different health system has a different looking form with different questions on it. Most of them make you fill it out in person. Some require a notary. And if you can do it electronically, they usually send it to you or have you download it from their website. But you have to be savvy enough to print that out, sign it, and either scan it or fax it to them, which most patients just aren't really that savvy to do that or really have the desire. So the first thing is that. Now it is getting better. We're starting to get all these patient portals where they give you access where you can just log in and start to look at your information. So this is one of the examples of the logins from Morgan's patient portal. And as you can see, we've gotten quite a few of these. So this is another one. This is another. It looks like the first one, but it's really not because it's a different health system. So when we log in, they look the same, but they have different sets of information. There's another one, and another one, and another one, and another one. So she's up to 7 patient portals at this point, all with different stories in them. So we really have to get to the point where patients have all of their information, and it's really not that hard. It's all of these have different password requirements, so I can't even use the same login and password. So it's hard to remember all of that information. So the next thing is meaningful information. So getting access to the information is great, but I like to carry this prop around with me, even though it's heavy in my suitcase. This is 1 year of one doctor's record for Morgan, 1 year of one doctor. So you can imagine trying to look for something in this if they ask me for a test result. It takes me a long time to find that. But it's not just me. The doctors get this information. Morgan's pediatrician actually asked me to stop listing him as her pediatrician because he gets so much paperwork from all these other doctors and he can't process it all. So, it's just too much. So we need to start figuring out ways to display it in a meaningful way. So as an example, when I logged into one of Morgan's patient portals, here's her lab results as the way they display them. So it's in a list view. It gives the normal values and the range. But for example, her SED rate has stayed high. But when you look at it on a graph, you can see that even though it's still high, her SED rate climbed, but then it came back down, and we've had a few spikes. But it's definitely trending downward. But if you just looked at whether it was normal or abnormal, that wouldn't have really told the whole story. But looking at this, you can see that it actually is trending in the right direction. Another example of documents, you can just look at documents one at a time, but on the right side, there's a timeline view where you can actually view the information in a medical timeline with summaries of bits and pieces of the information, just the important parts. And you can filter that information. So if you're just looking for information on she had meningitis twice in the last year, and the second time I could actually filter and show them exactly what happened the first time, what they did about it, and how to treat it. That's a lot harder to find in a stack of information than it is in a filterable list that I can share with someone. And then some of this gaming that's coming out is really helpful. So this is a medication tracking app. So it can kind of give you encouragement that you were perfect and you took your meds, or oops, you've missed some on these days. And so it just starts to put the data in a new perspective. So it's making that meaningful instead of just, asking how are you doing with your meds, and kind of gaming that a little bit. So the next barrier is collaboration. So as you can imagine from my story so far, Morgan has a lot of doctors. So these are just a few of them. She has some specialists at All Children's Hospital. She has 2 gastroenterologists in different states. She has a primary care doctor and a rheumatologist. She gets most of her care at one hospital, thankfully. She has specialists at a different health system in Tampa. She sees 2 super specialists in different states. And then she has a school nurse and a physical therapist. So that's a lot of caregivers that all have different healthcare systems, different EMRs, and they don't really talk to each other on a daily basis. But on top of that, she also has a lot of other people in her care team. Her parents, her siblings, her aunts and uncles, her grandparents, and even the CureJM network that we found. So it's really important to give different ways to collaborate. So this is one of the examples on the CureJM website. There's a message board where you can post, and other parents who live with this disease and helping manage their child every day, they can go and get help from other parents who have real day-to-day advice and help. Here's an example when Morgan got meningitis as a side effect from her IVIG treatment. I posted this online on our private Facebook group, and within 2 hours I had 56 responses from other parents telling me, when my child had this, this is what happened, and this is what you can expect. And I was able to take some of that information back to her doctor and share what's happened, because he only has 4 kids that have her disease. It's not like he's had a lot of experience with this particular issue. So it's been really helpful. And then the last barrier is communication and convenience. So I think Carly stated it really well this morning on stage, that she said, I have a full-time job and I have a full-time unpaid job as a patient, and I don't have time to be going around to all these different systems to do all these different things. So we really have to make it convenient. We need to make it easy for the patient because they're already struggling with enough. So this guy is really what I feel like a lot of the time when I try to interact with the healthcare system. I get all these menu-driven buttons, and it's one thing if you're just trying to get something that you have a few days time, you can wait. But if you're trying to get help of something pretty quickly or an answer immediately, or even just in the few minutes you have at work or something to make a phone call, it's challenging. So things just simple like messaging and email and making it easy for that. And then I like to say, meet patients where they are already. Use the tools that they already like to use. Like if you can allow text messaging, I know it's a controversial subject, but things that are simple, that you can allow people to do, and including social media, that's really helpful. So to summarize, the main barriers are to remove those barriers is to provide easy access to all of their information, not just some of it, not just their medications or their problems, but all of their health information. And then make that data meaningful so that they can actually use it, not just the patient, but also their family and their providers. And then provide ways for people to collaborate around that information and make that convenient to the patient so that it's easy. So just to step back a little bit to the beginning of the story with Morgan and her diagnosis, I later found out when I got all of her medical records that the biopsy from her tonsillectomy that she'd had when she was 6, 5 years before she started having any problems, said investigate autoimmune disease, but nobody ever told me that. Nobody ever told any of her doctors that, so nobody was aware of it. I found out that just because we were lucky, we got all of her tests the day before she went to camp. But if she had started her steroid treatment and then had the test later, we would have never had a baseline MRI from her disease. So there are a lot of things that happen along the way, and you have to learn to engage and get people, the help that they need. And patients that are engaged can get better care. Thank you.
We'll take a few minutes for questions. Have anything that is sort of commentary? It's going to take more than a few minutes. We ask that you hold them until the discussion. We have about 3 other speakers that want to speak. We'll take questions right now. So I actually have a question for you, Amy. So tell me about just sort of an eyeball estimate, just from your experience in terms of mom who's trying to work, who's trying to balance family life, trying to balance all these things. Can you give me an estimate, just in your experience, how much money you probably saved yourself in keeping all of these things organized compared to something like this? Just an estimate.
Sure. So I know that we've avoided having at least 4 MRIs because we had the results ourselves. So those are pretty expensive tests. We've probably avoided blood work almost at every visit that we have because they don't connect the blood work. So, I mean, it's thousands of dollars, I'm not sure. And then we found a solution we get her medications actually in pre-made bubble packs that I just found the solution, and that saves us $300 a year, and it delivers them in pre-dosed punch-out packs. So it makes it easier for her to take her medications, and it saves us money. So definitely being engaged also does have a financial impact. I'm not sure exactly how much, but. Any other questions? Okay. Well, I certainly share things as much as I can on social media. I write at least an annual post kind of what we've learned over our journey. And so I've shared some of that stuff on my personal blog and on Twitter. We also share a lot in our Cure Jam group, but that's a private group. Obviously, I built a company with some other people on called CareSync. That's mainly what we're trying to do is make it easier for patients and make them have meaningful information. So that's trying to give back to the community and make it an easier process.
Every state has its own regulation for pediatrics and access to data. 12 and 13 is often a barrier. Have you noticed all this data issues with?
Yes, so I'm glad you raised that, actually. So some of the organizations that she's seen in won't allow me to even have a portal login because she's 16, but they'll allow us to get paper records, but then they charge us $1 a page to get those records. But that's one of the things that CareSync actually does is we get the records even if they're on paper, and then we digitize them for people. So that's one of the ways that we worked around that because they have a process in place to manage it for paper, but they haven't figured out the processes to splice the digital data yet. That's what they tell me anyway, why it's that way.
I'm just wondering if you could tell us what you found or what you're doing with Morgan here to help her become and word is you're growing up and becoming more responsible. How you'll become.
So that's a great question. So one of the things we started doing when Morgan was first diagnosed is on the way to each visit, we would ask her, okay, what are you feeling? Think about how you're, because they ask you so many questions at ready fire that if you're not prepared and haven't thought about it, it's kind of difficult to answer. So especially like pain, they ask her how she's feeling. Well, when you're 11 or 12 or even 16 and they say, how are you feeling? You remember the last week, but maybe not the last month or 2 months. So we started kind of paying attention to that more and prepping her to think about it before the answers. And now she's pretty good at obviously telling she's older. But I'm not sure if you've seen her on YouTube, but she actually started her own YouTube channel and blog speaking out about patient experience. So she's well on her way to being, she's very outspoken. But it is an important, you have to teach people, actually, to quote Morgan, she said, you send people to medical school to become doctors, but you don't send people to patient school to become a patient. So it is very important to teach them. Yes. Not yet. Thank you.
I'm sure you've heard from Amy sort of the trials how challenging it could be to provide care for your family. I'm going to switch modes a little bit, and we're going to talk to Dr. Josh Reicher. He is a third-year radiology resident here at Stanford who has authored many articles surrounding patient engagement and also in innovation in breast care, as well as mammography imaging. And during his residency, he also co-founded a company focusing on secure health communication for patients so that they can be involved in their care. So we want to hear more about Josh's journey through developing such a program during residency and his perspective on managing patients through not only a physician's perspective, but engaging with patients and helping them to get access to their care. Without further ado, Dr. Reicher. Mm-hmm.
You guys hear me okay? Hear me okay? Yeah. Great. See if this thing's working. Hi, I'm Josh Reicher. As I was introduced, I'm a radiology resident here at Stanford. I'm also a co-founder of a company called Health Companion. We're a comprehensive consumer healthcare platform, patient portal, and patient engagement service. I'm going to talk a little bit about Health Companion today, but I actually am going to spend more time talking about some changes in the healthcare industry in terms of sharing data over the last 2 years and in the upcoming year. And I think that may be useful for everybody in a number of different ways. So what is Health Companion? You've seen a lot of services that cover similar topics: personal health records, so you can manage your care in a long-term way, prevention and wellness, so leveraging that data to do useful things with it. Health finance management, something I haven't seen talked about as much, but managing HSAs, FSAs, where you are in your deductible. And a social network, which for me really means the ability to interact with your healthcare team, anything from family to your providers. So I want to set some goals for today's presentation. I'm going to go kind of quickly, but if we set goals, hopefully we can achieve them. So the first one today is actually going to be that I want everyone to become experts in how to share healthcare data in sort of the new modern ecosystem. And the next, of course, is for everyone to sign up for Health Companion and tell all your friends. So, why? So that's kind of the first question. Why did we start Health Companion? What is this all about? And actually, I'm not going to spend much time on this because if you're at this conference, you already kind of believe in this stuff. This is patient engagement. It's owning your own records. I don't need to go into that too much. The concept is kind of like a mint for healthcare. The way that you manage your finances, you should be managing your health records. The way you use Microsoft or Google or Apple to manage your contacts, it should be the same thing with your healthcare data. So the real question for me is why now? So those of you who are kind of into and aware of this industry, which again is probably everyone in this room, you know that Google was in the personal health record business and put some significant time and energy into that and then stepped out a few years ago. You may know that Microsoft has their product Health Vault, which I don't know how many people have full-time use of Health Vault, but it's fairly limited in its success. So why do we think this has changed? So there's two big areas. This is what we're going to talk about. One is infrastructure and the other is trust. Those are kind of nebulous ideas. I'm going to go into some detail about exactly what that means and why we think it's a new era right now. So the first one is infrastructure. And when I say infrastructure, I mean infrastructure in the healthcare system in the United States. And I'm going to break this down into kind of 4 areas. So the first is the cloud, which is finally making its way into the storage and management of healthcare data. All the same benefits of cloud-based technology that apply in IT in general apply in healthcare. The next is the law, So many of you probably know a decent amount about Affordable Care Act and its impact in electronic health records. Over $24 billion have been invested in the last 2 years alone just in encouraging doctors to use electronic health records, not to mention the amount that's gone into developing those and distributing them. Next is standards. So if you want to communicate data in a meaningful way, really applies to communication in general, you have to have standards. You have to have a way that different vendors and different systems can understand. And then the last is kind of a new area that I call the exchange, and it's a new technology called an HISP, and I'm going to show you really what that means for those of you who haven't heard of it. So kind of pictographically, this is how the old days would work. So here we have Allscripts, one of the largest electronic medical record vendors in the country, and then you have Health Companion, another health record vendor. So how did you get information from one to the other and back and forth? And the answer was a lot of time and a lot of money. Very, very difficult process. For those of you who know HL7 interfaces, that's done on a one-to-one basis, so it's not just vendor to vendor, it's provider to provider. It's very time-consuming to keep these up, so it's a real effort. So this is where this new infrastructure comes into place. So I'm going to draw a parallel to email and how email was developed and sort of works in a very simple way. I'm a doctor, not a tech person. This goes. There we go. So if you had two different email vendors, you had Gmail and you had Outlook, someone using Hotmail and Outlook, and you want to communicate information between those two, those are different technologies, they're operated by different teams and different companies. How can they communicate? And the answer is you had to have an ISP, an internet service provider, sitting in between them that provided the service of actually transmitting the data across those systems. The other thing that you need is you actually need a standard for how you can communicate that information so that both systems understand it. So now, if Gmail knows this is an HTML-based format, and I can actually read and transmit this data in a meaningful way through this ISP, now you have interoperability. So this is what is currently being implemented nationwide across the healthcare system. There was something called the Direct Project that was started in 2009 or 2010 that is now really coming into full effect. And it follows this scheme in a totally parallel manner. So again, we have our EMR Allscripts here. And then we have another health record vendor like Health Companion. There's actually a new entity called an HISP, which again is made to just completely parallel this ISP above. And that serves to transmit data across these systems. And we have a standard, which is a format of document called a C-CDA. This stuff is mandated now that all certified electronic health records follow this and support this technology. And over 80% of hospitals and over 60% of providers are already have this in place, or it's being implemented right now. And I would say that the vast majority are in that second category. Technically, it has to be in by January 1, so we'll see what happens in the next 3 months. The next big area is trust. Trust, really the question is, why do two facilities or, a hospital to a patient, why do we trust that we can send our healthcare data back and forth and that we know what we're receiving is reliable? It's a very risky endeavor. If you lose health data, you can lose a lot of money. So there's a couple different areas. One is the ACO, which is institutions that were independent are now under a single umbrella, so they automatically have incentives to really trust each other in terms of sharing data. The next is HIEs, which has been another big change nationwide. We have a lot of state-run health information exchange entities. Employers and payers are pushing and getting more involved in this area as well. And then there's actually organizations, and I'll plug one that I'm not related to, but Direct Trust, which is a great organization that I encourage everyone to look into, that really focuses just on this issue of trust. So in the old days, you had hospitals A, B, and C, and they weren't sharing data in any way. And I can tell you as an intern at the county hospital here 2 years ago, we were still calling people and sending faxes, and you'd only get part of the data. You couldn't do anything useful with it. Patients were, of course, left completely out of the loop. And that was this whole process we heard about a moment ago where, you're still getting paper records. So this is what the new system really looks like, is you've got an ACO now covering hospitals A and B, so they're sharing health data in a meaningful way. Hospital C is still independent, but because of the state-run health information exchange and using these other entities like Direct Trust, they're able to communicate data back and forth. And again, there's building incentives to do so. And now all of them are incentivized to get this data into the hands of the patient, again, for all these same sorts of reasons. Now, I thought this was a wonderful segue into what I want to talk about as well here, which is this issue of the 7 patient portals. So because of the way these laws were written and the implementation has gone, each hospital A, B, and C have all built their own separate patient portal. So if you're a patient that's getting referred to different doctors, or you move, most people stay in one job for an average of 2 years now. You change health insurance plans, any of these reasons, if you want to get your health data, you have a separate patient portal, it's fragmented data, you can't access it in any reasonable way. And this is where products like ours with Health Companion and others like CareSync and many other wonderful products that we've seen at this conference are really going to come into play, is to say, you know what, this doesn't make any sense that there's a separate portal for each of these facilities that only has fragmented data. There's one patient that's responsible for all of this data and should have access to everything. Okay, so that was kind of a lot of technical detail. I apologize for it on the one hand. On the other hand, I think it's really important for patients and for other people in general to understand what this impact really means, okay? That whole infrastructure that I talked about, this one here, there's no reason that a patient can't participate at the exact same level as any of these facilities. You have an equal right, and in fact, it's built to support your ability to message and do all sorts of interaction in the same level as these hospitals and clinics. So what does that really all mean for me as a patient? Where is this going moving forward? Again, this is where our platform, we see some opportunity. So personal health records, prevention and wellness, health finances, and secure communication. This is our homepage. This is a snapshot of our personal health record. You can take a look at that online today if you're interested. What's important about this is no matter where you get these documents from, these C-CDA documents, whether they're securely messaged to you or you get them from one of these patient portals for now, however else, you can incorporate all of that data automatically. Because they're coming in a standard format, we can take data from any EMR source and incorporate it in a meaningful way. So you don't end up with coronary artery disease listed 27 times on your problem list because it's at a few different facilities. And you have a reconciled medication list that just has the true summary of your information. In fact, you can turn this around, summarize this information, and instead of next time going into your doctor's appointment having to fill out the little form of your whole history, you can just hand them your information in electronic format or send it to them directly. I think it's actually worthwhile just seeing kind of what these documents look like, these C-CDA documents. So they're not the prettiest thing in the world, but the important thing is that they're a standard. And you can see here they've got kind of coded numbers. We're just looking at the medications. It's got the name, the dose, the route, the frequency. And the important thing is because we know how it's going to look, Health Companion, and again, any other electronic health record can take that information and do something useful with it and put it back into their own system. You can leverage it to do things like secure messaging. So you can email your doctor directly through the system, no matter what system they're using, it'll show up in their inbox. Use things like appointment reminders, refill requests. And then we take all that information and we actually built on top of that a prevention and wellness section, which is based on evidence-based measures, which looks at your risk factors and a few specific questions that we ask on top of that. And we can take that information and tell you actually what you're due for based on those risk factors. So we look at your family history, any congenital diseases, whatever else, and can say, you know what, you're at particular risk for X disease. You need to be screened at an earlier age based on national guidelines. This piece people often like to take a look at, and the naysayer response that I typically get is, oh, my doctor takes care of that. I probably don't hear that too much at this conference. But it's surprising how you would think there's usually only 5 or 10 things, and you think, oh, I'm probably up to date on this. Very, very few people that you meet that actually are up to date on all of their recommended preventive measures. And this is not getting outside of the norm of what your average practice should be. We've added in beta a component for insurance and finance tracking. So you can manually input data on HSA, FSA, where you are on your deductible. And we hope down the line to be able to add that in an automated fashion. And I'm not going to spend any time on it right now, but there's clear plugins for employers, payers, and consumer health vendors, devices, things like that to plug into similar systems like this in order to link into the healthcare system. So the way we see the new health data workflow moving forward, regardless of what the back-end technology is going to be, is you're going to sign up for your own personal health record. You're going to have a number of vendors to choose from. Your doctor is going to have the ability to query information from your account before your visit, instead of having to have you fill it out in a manual way. And at the end, they're going to be able to send results back to you. I don't know if this is 6 months away or 5 years, but it's definitely on the horizon, and it's a lot closer than it's ever been. So thank you very much for your time, and happy to answer any questions. Yeah.
Can I ask a question?
Please.
As physicians, we get records from multiple facilities. Head lists are different, problem lists are different, data is different.
Yeah.
So when data from different portals comes into a common place, who decides what the real problem list is and what the real medication list is?
It's a great question. I'm not going to pretend that I really know the answer to that. And it's really kind of a system question in general. We've seen in the last few years, 10 years ago, if you had asked the hospital, I have a problem list, I'm going to send it to you in electronic format. Would you be willing to incorporate that directly into your health record? The answer would have been, no way. No, we're not going to trust the patient, which of course is ridiculous because that's where they're getting the information. They're just getting it because you're telling them. We've seen a lot of prominent facilities move away from that and start to realize that the reality is, if the data is coming from the patient, that's probably just as or often more accurate than if it's coming from anywhere else. So in particular, the Mayo Clinic recently kind of opened up its security and is starting to accept more information into their system, that was kind of a big moment, I think, in healthcare over the last couple of years. So I think moving forward, we're going to see a lot more flexibility. Now, some systems may decide that there's an intermediary point where they want to review the data and then sort of incorporate it the way we do with medication reconciliation today. So I think that's possible too. So the groups that we work with today, we primarily work with providers. On the provider side, providers have a lot of both financial and otherwise incentives to start communicating their health data to patients. Patients are more than willing to use the system if you provide it to them. So we show that if you tell a patient in person, sign up for this record and you can see your data, maybe 5% sign up, something like that. If you send them one email to tell them to do it, you might bump it to 20% or more. And if you send them things like with some of our practices, their radiology report, a couple of days after they have their radiology study, so they have direct access to it, they're far, far more likely to participate. So I think it's really a question of kind of value. Technically, yes. I think it comes back to this question a little bit of kind of what the demand is there. From the provider side, there's lots of reasons. We incorporate images in general and PDFs and all those sorts of things, but radiology images as files can be up to 1 gigabyte or more in size. So it's a question of, is this something that we're going to be storing in a long-term way, and how do you deal with the questions of cost there? Yeah, sure. Where's our little clicker here? So this is our prevention and wellness algorithm. So we can take the records that you've brought into the system, and then, as I mentioned, we ask a few additional risk questions about, lifetime risk of breast cancer, your family history, those sorts of things. And with that, we can leverage national guidelines that we've put together into an algorithm to determine, okay, what is it that you're actually recommended for based on those risk factors? And there's a lot of funny things people would never think about, which is that people that were born in a certain era in the 60s are actually at risk for hepatitis C and have to have hepatitis C screening. It's not based on a lifestyle or anything else. So there's a lot of things like that that come out of that data that patients may not even be aware of. So if you really want to be healthy, you have to be sort of proactive in finding that. And are we out of time here?
One more question.
Okay. That's the question. I think for personal health records in general, it's a big question. And I think that's why one of the reasons we've really seen a lot of limitations and success so far. Frankly, I'm a physician, so our focus has been the physician universe. We see the greatest utility of these things when you can actually get your health records and your health data. That's been our focus so far. I think, we have designed, and there are many other business models that you could put into play here, including insurance companies, consumer healthcare vendors, and employers, all of which we have looked at some trials with for the long term. But I think for us right now, the biggest focus is getting the data. And as I mentioned, our providers pay us for the ability just to communicate to patients because they're incentivized financially to do so. Okay.
So we've heard it from a nurse's perspective. We've heard it from a clinician's perspective. Now I'm going to introduce Jan Oldenburg, who has a very unique perspective on this, in that she has extensive experience in the accountable care organization experience from a patient engagement. She has chaired and sat on many boards through the Health Information Management Society, Society, and has recently won a book award for her book, Engage, that was celebrated at this year's HIMSS conference. And she currently has her own consulting firm focused on patient engagement and improving that experience for patients. And it has also been named the advisor at Ernst & Young as the healthcare advisor there, most recently in May. So without further ado, Jan Oldenburg.
Can you hear me? Great. I'm not going to stand behind the podium because you'll never see me. One of the disadvantages of being short. And as noted today, oops, I guess I'd better put my slides up, huh? Okay, there we go. Now we're ready to roll. What I'm going to talk about today is really about the way we need to build policy, infrastructure, and community in order to really engage patients. And I want to do this by virtue of telling some stories. I'm going to tell 3 patient stories. I've been working on a new book about patient engagement from the standpoint of the patients and caregivers. So I'm going to use those patient stories to really talk about what some of the policy and community implications are. So I'm going to start with a story about Kelly. Kelly is 40. He's a freelance photographer, been on his own for quite a while. So he's actually carried his own insurance since about 1995. Right now, he is in an exchange policy, but it's got a really high deductible. He's got a $6,500 deductible. So when Kelly gets health care, he's a cost-conscious shopper, and he's a cost-conscious shopper because he's got to be. It comes directly out of his pocketbook for the most part. So this is first a story about how Kelly needed an ultrasound. He went to his provider. Guy said, I think you need an ultrasound, actually for a nodule on his testicle. And go down to the front desk, they'll get it scheduled. Kelly said, what will it cost? I don't know, they'll tell you at the front desk. Front desk didn't know, told him to call billing office. Billing office told him he needed a code. Gets the code. It's going to cost $800. Well, this is a lot of money to Kelly. So he goes back to his provider via email and says, is there anything else I can do? It's going to cost me $800. So his provider said, well, I don't know, I'll send you to a urologist. But when he called the urologist, they said, oh, we're going to need an ultrasound. So then he decided he would go to his insurance site and see if they had a cost estimator to see whether he would get any discounts. Sure enough, they had a cost estimator, but his procedure wasn't on it. So it really didn't help him much. Then he went to provider directory and started looking at other providers in his area. He lived in Madison, Wisconsin, where he could perhaps get a price from somebody else. Called 6 different providers, actually did find an ultrasound for half the price, happened actually to be at a hospital that his doctor practiced at, so he could get the ultrasound. Goes in for the procedure and indeed has the ultrasound. All is good. It's going to cost him $400. Until, of course, he gets the bill, and then guess what? It's $400, yes, but there's also a charge for an additional $125. What's this? He has to make a call. And they tell him, well, as long as we were doing the ultrasound, we did another scan because, you know, it's just to make sure nothing else is going on down there. He's like, I'm lucid. I was there. I was awake. Why didn't you ask me? I didn't authorize this. And they say, oh, we never ask the patients, but don't worry, your insurance is going to cover it. No, not my insurance. I'm essentially self-insured until $6,500. So he had to make 2 more phone calls to get that charge removed. All in all, it took, I believe, 15 phone calls, 2 emails to his doctor, several web searches to actually get a price. Now, really, how many people are going to do this? You can tell Kelly got the bit between his teeth at some point. He was like, I'm going to get this. I'm going to get this price and I'm going to get it lower. But most people don't have the time or the energy to do that. So what are some of the things we can learn from this about policy implications? Certainly one of them is that if we really want people to be cost-conscious consumers, we've got to make it as easy for them to compare costs in healthcare as it is to compare the cost of buying an iPhone or a mattress. But the other thing is we've got to stop using excuses to not be transparent about the price data. One of the things that bothered the heck out of him is when he asked, well, so is my insurance going to have a different price than the one you're telling him? They said, oh, yes, absolutely. We've got negotiated rates. He said, so what would that be with my insurance? Oh, we can't tell you that. It's confidential. Well, it's not confidential when he gets it on his bill. So why is it confidential when he calls on the phone? Again, we've got to think about this differently. And one of the things that we've got the opportunity to think about when we're dealing with price information is that, of course, healthcare isn't just about cost. There's a whole quality dimension. And we haven't given consumers a clear way of thinking about what that dimension is. In every other aspect of their lives, they look at cost as a proxy for quality, right? Hotels, purses, you name it. We can usually think that the amount we're going to pay for something is a reflection of its quality. So in healthcare, that's not necessarily true, but we haven't helped people think about what that is. We need to engage in a whole new conversation about value in healthcare. that both helps people understand transparently the costs, but also the quality of what they're getting. Now their story. This is Whitney. Whitney is 33. She's a new mother. She's got a newborn and a 2-year-old. She lives in a major metropolitan area, Washington, D.C. And Whitney's a tech-savvy person. When she got married, she used the knot to help manage her marriage process. When she looked for a house with her husband, they used the Nest. When she got pregnant, they used the Bump. She uses a Fitbit to track her steps and exercise. And now with her baby, she's using a Total Baby app. But guess what? Even though she's clearly very engaged around her health and very tech savvy, and even though she lives in a major metropolitan area, she doesn't actually have access to either her data or her children's data online. She doesn't have the convenience of using a web or app feature to make an appointment. She can't refill prescriptions online, and she doesn't have access to her medical records or email with her doctor. So in a situation like this, Whitney is operating in a system that is neither as convenient nor as connected as she expects and deserves. So the lessons we can learn from thinking about this situation is that if we're going to keep up with the connected consumers like Whitney, we have to be both more digital and more convenient than we currently are, certainly. And we've got to actually think about keeping up with the people in the consumer products space, in the hotels, in travel, in the other aspects of their lives that they have been used to these kinds of service, because they translate those expectations into their healthcare experience. We've got to think about how we use technology to connect people and their data together to provide a clear health history that incorporates that self-generated data. And we've got to think about connected communities that are both virtual and in person to help meet the needs of everybody and help them build those personal connections that are a part of being well and staying well. Third story is about Don. Don's 68. He is a person with multiple chronic conditions. He has diabetes, which was diagnosed in 1999. He has heart disease. It started with AFib, so he got an implanted defibrillator in 2008, and open heart surgery this last year. He is depressed. And as he says, I've been fat all my life. This is just how I am and who I am. He is now covered by Medicare and Medicaid. But when he had the implanted defibrillator, which cost him $100,000, he didn't have insurance. So he's paying that off, $100 a month. And Don hit rock bottom in 2008. He had depression from his brother dying in 2003, had gone undiagnosed for 5 years. He lost his job. He lost his house. He was living in his car. His diabetes was completely out of control. And he was able to reach out and get care from a nonprofit. And actually from a clinician who had a sliding fee scale. And the clinician started helping him at least get in touch with his depression and some of the causes of it. But he was still in this vicious cycle. When you are depressed, when you are sick, it's very hard, and not feeling connected to your community, it's very hard to take action to change your healthcare situation. But his doctor, his therapist, put him in connection with a group called the Community Clubhouse. I don't know if any of you know about it. It's an international nonprofit. And it's particularly for helping people with mental illness, and in a very self-generating way, so that the patients and the community members actually run the institution. They helped him understand his condition. They helped him get disability started, helped him find a job, helped him find housing, and they helped him believe in himself. They became his family. And as a result of that, spurred perhaps by the fact that just as his life seemed to be coming together last year, he found himself needing another open heart surgery because he had several blockages. He took stock of his life. And after his surgery, he was put on a strict diet. He's also in the early stages of congestive heart failure. And he started going to a water exercise class. He lost 65 pounds. He lost his cane. He lost his warfarin. And he's got a new lease on life. This is Don. Before, on the right, and after, on the left. He was able to go to his 40th class reunion, a completely new person, somebody that people who had known him from childhood didn't even fathom that this was the same Don that they'd known and loved. So what can we learn from this situation? I think one of them is that you never know, we still do not know what it is that makes any given individual choose a moment to change his or her life. Don's the kind of person that it's easy, it would have been easy to give up on. We do this all the time in healthcare because somebody hasn't responded to all of our entreaties to change. They are complex. Lots of things are interconnected, and it feels hopeless to do it. But Don's a great example of how we need to meet people when and how they are. We have to figure out ways of getting them connected to a community that's greater than the healthcare community, that will give them some of that support that we don't necessarily have the time, the space, the energy to do. And as we do that, we never know sort of what will be the cue that makes somebody choose to take that moment to change their lives. So as I think about the lessons that I've learned from these folks that I've chosen to highlight here, and also from a variety of other patients and caregivers that I have been interviewing, I think there are a couple of key lessons. One, we've heard this whole thing about we've got to have an infrastructure that actually works for people, where when we create things like high deductible policies, we actually think about what the tools people will need in order to manage those are. We've got to make it easy to incorporate patient-entered data with clinical data to look at trends that cover both so that people can get a full picture of their health. We, I think, here in this room, in this conference, know more than anybody else that we've got to figure out how to innovate at the pace of the connected consumers out there. But this is not something that everybody in medicine understands. And in healthcare understands. We've also got to think about how to create these communities and connect people to communities, both the digital ones, but also the physical ones, and what are those connections and how do we help people make them? And then last, but surely not least, I think we need to remember that transformation is truly possible at any age and any stage. And part of our job is to help people maintain hope so that they can, in fact, do that for themselves. So please reach out to me. I'd love to talk. And open to any questions. Yes. Yes, hi. Yeah, it's a great question. You know, I think it's going to apply more and more, quite honestly. But we've got a lot of incentives that go crosswise in healthcare. So on the one hand, you've got the high deductible plans that have you taking a certain percentage of the costs and trying to manage that. On the other hand, and what that means is you shop for the cheapest price, you know, kind of wherever it is. But exactly, and precisely because they have high deductible plans that make it hard to get even the most basic care. Kelly had another part of his story where one of the things that he went in for a annual physical, free, part of his plan, and his doctor said, well, any other issues you want to talk about? He said, well, I'm kind of afraid to raise it because I think you'll charge me more. And his doctor said, oh, that won't happen. So he asked his question. Doctor referred him for physical therapy, which he didn't go to, mind you, because it was going to cost him too much. Guess what? Got an extra charge for an office visit rather than a preventive care visit that was free because he'd asked that question. Is that really what we want to have happen? Is that really the method we want to approach? So I think it's a great point that we've got to think through kind of the layered incentives. I also think that if I buy a cheap plan with a high deductible or a narrow network, give me an option so that I can buy, say, a personal reinsurance policy, that if I end up with cancer this year, I could go to Mayo, or I could go to Stanford, or I could go to MD Anderson. Give me some outs so I don't get trapped into this kind of war about, oh my God, I bought a policy that seemed reasonable until I needed to use it. Yes? Right. Alexandra Drain talks about this. She's not here right now, but she's at the conference. She talks about cost as one of the great unmentionables in healthcare. You know, it's a presence in every conversation about health and treatment. It's in the room between doctors and patients, but it's very rarely talked about. It has a huge impact on whether patients, in fact, follow an agreed upon course of treatment, because when they actually figure out the price, they may not be able to afford it. They may be too embarrassed to ask the questions that Kelly was so brave and so persistent about asking. And they may also feel embarrassed that cost is an issue for them, and they don't want to be perceived as that kind of a person who actually worries about cost. Or it's for a loved one, and they don't want to look at the fact that this makes them think about what's the price of their loved one's life or health. So we, I think, really need to figure out ways to bring it from the unmentionable companion in the room out into the open. It is as much a factor in shared decision-making as the actual course of treatment, the efficacy of the treatment, and the values that the patient brings into it. So it's, I think we are at a moment when there's an opportunity to start having those conversations, but we've really got to think about what the infrastructure components that support it are. Anything else, or are you guys ready to almost go to drinks? I'm not chasing them away. Not chasing them away. They're not serving until he's done. Okay.
So before we go to drinks, before we go to drinks, we have our final speaker this afternoon, who has a very interesting perspective. He is a clinician, but I think that his perspective is very intriguing because his story is from the patient, which I think is unique. You know, oftentimes When someone tells you that they are a physician, we often forget that physicians will be patients as well. So his story is interesting, and without further ado, I want to make sure I say it right. Dr. Joseph Salish.
Thank you very much. I'm not sure. Does anybody know how to get rid of my slides on the left side of the screen here?
Yes, just go to slideshow up top. Very top, very top. There you go.
There we go. Is that, oh. There we go. All righty. So put this on. So I want to tell you that I had planned on singing a song, and Arnold Schwarzenegger was going to chime in with me. But Josh in the front row, no, he decided he wouldn't. Can everybody hear me? Okay. No, I think that I'm very blessed to have you guys all still here with us for sort of the last talk of the day before cocktails. And so I do appreciate that. I'll try to be somewhat entertaining maybe. I'm not sure why they stuck me in with this wonderful group. I'm in awe of the work that goes into all this brainiac kind of work that I've been experiencing. I'm in awe of the wow impact of the conferences and the speakers that I've heard thus far. Mine, I don't think has wow impact. I think I'm more like a case study. And so I think we're going to take it from all the out here to all the down low. So can you guys hear me? It sounds funny up here, but anyway, I think that you should need to know that my presentation is not high tech in any way, except there's light projecting on the screen. I learned how to Twitter yesterday, not tweet, how to tweet yesterday on Twitter. And, but the idea that I came up with through a personal story is not high tech, but it may be world changing, maybe life changing. It speaks to some basics of human dignity, and some of the very basics of human dignity are your own self-image, how you view yourself, and body odor. How about that? So people sitting next to you, hopefully notwithstanding, you'll have a good conference or good discussion here. So let's see. Okay. So I had a lightning bolt strike me in 2010, almost exactly 4 years ago. I'm a urologist, which is a plumber of sorts. Morgan sitting in the middle, I might have to explain a little bit about what that means, but I work with the waterworks in the body. I'm a surgeon. I was trained to take things apart, put them back together again. And you may have all heard or not heard about a substance called a PSA, which is prostate-specific antigen. It's received a lot of bad press lately, indicating that it's probably not a great tool to find prostate cancer. But guess what? It found mine. I had a PSA that went from 1.6 to 28 in 1 year. And I've had a number of my patients ask me, so is this contagious? How, you take care of prostate cancer patients, right? How'd you get this? Well, you know, an ophthalmologist can have an eye problem, a cardiologist can have a heart attack, a dentist can get a tooth abscess. I mean, I'm human, so can I get prostate cancer? Yeah. Was I paying attention to it? I actually was. I'm a believer in using PSA, and my PSA suddenly was higher, and I was in trouble. I actually reached out to my partner to do biopsies. Then I reached out to my community in Michigan. I'm from right about there in Michigan. And my community suggested that me as a surgeon, perhaps the best treatment was going to be surgery. But that was thinking outside the box. The big typical thing that people have when they had illness like mine would be to have radiation therapy and chemotherapy. And being a surgeon, I didn't like that idea. Those things seemed like voodoo to me, so I decided that I wanted to have surgery. Discussed this with every person I could in the state and chose a couple of key people to advise me, and figured out all things were pointing to a certain person at the University of Michigan to operate on me. So I used my community. We talked about your resources. Boy, if you've got community, you've got a lot. So the other thing about me, besides being a surgeon, is that I fancy myself a bit of a musician. This is a guitar. Since I had an illness, I designed a bucket list. You never think of a bucket list until you get close to something that impacts your life like that. And one of the things I wanted to do was have those big speakers alongside me. I'd taken some guitar lessons, and I got a keg of beer, and I had all my friends come, and then I hired a good band to follow me, and they came and listened to me, and they asked me to do it again the following year, which was a ball. Anyway, so I had my plumbing rerouted because of my bad cancer, and now I wear an appliance bag on my side, on my belly. What that means is that your urinary system is supposed to convey urine out through a normal process, and your stool goes out a different direction, of course. I had to have my bladder removed because of how bad my cancer was, and so I ended up with an ostomy on my side. This is a picture that was actually came across Facebook, and this is a very cute kid with an ostomy bag. This was not for cancer. I understood that this was put on Facebook by the Crohn's Ulcerative Colitis Support Group as a Facebook entry asking for 1,000 likes for this little guy. And so I don't know what benefit that brings to this little guy, but I do know it benefits his family. It's sort of like generating community. And when you have community that's pulling for you and tweeting you and Facebooking you and all that kind of stuff, it puts a little bit of a cushion underneath you. I had my church, my family, my partners, my nurses, and your community just really helps buffer hitting rock bottom. So hopefully this little guy will get his 1,000 likes. And I don't know that his family asked for that. I don't know how he got into that certain spot. And I actually had to blot out his eyes because if that was me, I don't know if I'd want to have everybody see my belly. But this little guy, it shows how important illnesses are and how important it is to develop a community. I think it's frankly sad. You guys might disagree with me, but it's frankly sad, although I've seen some connectivity with Twitter and things like that around here, if your only community is electronic. I think that's a hard situation to live in because I don't think electronics hug you very well. This is what ostomies look like. Ostomies are not normal. People with ostomies don't feel confident. They avoid intimacy. They worry about leaks from their plastic bags. Although the companies that make these plastic compliance bags are awesome. I saw a picture of a kid in Africa that had an ostomy, and he had a tuna fish can taped over with duct tape around his waist to his ostomy. So at least if in our developed country we don't have to do that with tuna fish cans. At least maybe there's some people in our community that may have to. But they have these bags that are available, and the bags really serve a purpose. They collect whatever's conveyed to the outside, but they're not perfect. And because they're not perfect, people with ostomies worry. They're not as confident as they had been before. Their life image, their body image has changed. And here it comes. The biggest problem that I view of it is that there's an odor. Now, just like the little boy that I showed in the last slide, interestingly, I've had 4 kids. I'm not a great diaper changer. My kids are all older now, and I really don't look forward to their kids having to have their diapers changed. But anybody that's in here that's old enough that has changed a diaper knows what a poopy diaper smells like. And generally it smells like this. You give it to your spouse, right? And so that poor little kid, that poor little guy with that ostomy is going to, as a toddler, maybe pull the bag off. He's going to have wardrobe malfunctions. He's going to have leaks. When he gets to be in middle school, he may be bullied. When he gets to be a teenager, he may not be able to play a sport that he'd like to play because of it. When he tries to date, he may worry about his confidence level, that he may have a hard time approaching a girl. And a lot of it goes into the parenting and the community that surrounds him. Maybe not. Maybe this little guy will do okay. But I was in this position. I was looking in the mirror into my eyeballs, which, if you've never done it, is an interesting experience. Look in your eyes, because the eyes don't change unless you've had some kind of eye surgery. But your body image may change, and your perception of yourself may change. But in that perception change, the question is whether you can do something about it. Problems with ostomy appliances. They're plastic appliance bags that cause perspiration, bacterial and yeast growth underneath. It's like strapping a Ziploc to your side, filling it up with something and having it hanging there. In this California climate, it would get pretty sweaty underneath, and then the next thing you know, you got yeast and bacterial growth. They get real itchy. They're not fun to have. This leads to skin breakdown. The bag makes a scrunchy sound, so people are afraid to hug you. If they know you've got it, they're afraid something bad might happen if they hug you. The contents are visible if you're trying to work out in the gym or if you're getting undressed in the doctor's lounge like I do. You know, the thing is hanging out. It doesn't look very good. The contents are wet and odorous. Now, my wife tells me that she could never smell my ostomy, and she's my wonderful support group. But I knew that when I wafted the blankets up in the middle of the night, it was either my feet or my ostomy. I could smell something, and just didn't smell like I used to smell. And I could try to blame my wife, and she always said it wasn't her fault. But I'm pretty sure that my ostomy didn't smell perfect, even though I had this wonderful collection bag. So the MacGyver principle, for those, anybody remember MacGyver? You know, this is from the 3-channel TV days, right? MacGyver he was an inventor, and the TV show always got him into odd situations where he'd have to make something out of something on the ground or build something out of paperclip in his pocket to get out of difficult situations. Well, I think, the MacGyver principle, and everybody's heard the rest of this, necessity is the mother of invention. That led me down a path of finding out who my community was and what can I do better. So my team initially included my wife again being my biggest cheerleader. Hopefully she feels that I'm her biggest cheerleader. She started looking online for appliance bag covers. So there are companies out there that take material and sew them into a shape that fits on the outside of your plastic bag. So it masks its appearance, may feel more comfortable than the plastic that you've got wearing on your side. We ordered a couple of them, and they were stiff. They weren't designed appropriately for my specific body habitus or bag. So I wasn't real happy with them. I didn't think they were great. They didn't really feel like underwear. They felt like cardboard. But she was working on it, and she knew that I was kind of down in the dumps, and I was a very active person prior. I was very busy, had an active outdoor life. I'm an active surgeon, got a very wonderful life, very blessed, but not feeling quite so at that time. I had a nurse at the time whose husband was a patient of mine, and he had a similar urologic problem in that he had tubes draining out, and the tubes were odorous, and she happened to be brainstorming with me and said, there's got to be something better. How can we avoid the smell of my husband, and how can we help you at the same time? That was me. I had partners that we assembled. Brian Stork in the audience is one of my partners. And we formed a team called Med5, and I don't know why we called it Med5, except there were originally 5 people, and it was something medically related. And when you try to come up with a name of a corporation, you have to search to make sure you're not copying somebody. But anyway, we came up with this idea. And the group included very important key people. We had a marketer, because we thought maybe this is something we're going to make it for me, but maybe we need to try to figure out how to make it for other people. We had somebody who was sort of in the business of publication or presentation or marketing. We had to have a guy, Brian, who's much more techno-savvy than me. And if you want to tweet anybody about all this stuff, go to Stork Brian at Stork Brian or something like that, I guess called. You can ask him. He's laughing in the third row here. But we also in Muskegon, where we're from, is a blue collar manufacturing town, and I happen to have a very close friend who was in the textile business, clothing business, and he made clothes for hunters, which I was one of. I'm a bow hunter, and if any of you understand the practice of bow hunting, it's doing something very primitive to try to kill an animal for the purpose of eating it. There are other reasons people hunt, but that's the reason I do it, is to try to do a field to fork mentality, and there's a lot about that now. Instead of going and purchasing a steak at the store, and understanding the whole process of getting where the meat is coming from and how to get it to the table. Anyway, he made clothes that were carbon impregnated, and activated carbon, which is charged by energizing it in the dryer, just heating it up, makes it so that it's thirsty for molecules that are charged. And many odor molecules that the body produces, or that are produced in the urine or in stool, are charged particles that will stick to carbon. Okay, it's like ammonia in your fish tank gets stuck to charcoal in the back of you have to throw the charcoal away after a while. Well, this activated carbon in these clothes can be reactivated by just putting it in the dryer. And typically the clothes last with a charge every 2 weeks. It only has to be recharged every 2 weeks. Well, I asked him, can we make a bag? I was actually getting ready to go on a bear hunt in Idaho with my 2 sons, and bears have a long snout. Why do they have a long snout? Well, they have a long snout to smell things. They have a wonderful olfactory system to find food and to avoid their own dangers, and to find each other probably. Well, I was going on a bear hunt, and I had to get to within 30 yards of it with my bow hunting experience, and I was worried about, what am I going to do? Let's build a bag. So I talked to this guy. He helped me build a bag, and this is sort of a schematic of what it looks like. If there's odors that are coming from below, they go up into this polyester fabric layer that has carbon stuck to it, and so many of the odor molecules don't quite get outside, and so it doesn't completely eliminate odor, but it cuts down on it. The other benefit that we had with this material that I didn't quite realize is that polyester in certain weaves is a moisture wicking, has a moisture wicking property. So it would take away not only the moisture of perspiration under the bag, but also small leaks, which is awesome. In addition, to the carbonation of this material, they attached an indelible antimicrobial, so that would be, in our instance, also helpful at preventing yeast and bacterial infections. This is what it looks like. So this patient has an ostomy. It's a bag that doesn't look all that great. This is our ostomy appliance over it, and that's neatly tucked into the underwear. Now, this is a woman named Tyla Syke, who I have to give a lot of credit to. She lives in the United Kingdom, and before I tell you about her, I want to tell you about a funny story. I was at a meeting where I was presenting like this, and everybody, you could tell in the audience was semi-feeling sorry for me, which is a wonderful thing because I got this terrible ostomy. The patient came out of the thing after I talked, and he said, my wife would really connect with you. I said, well, cool, that's neat. Why? He said, well, she had colon surgery for Crohn's disease and now has a colostomy. And I said, well, that's wonderful. I said, she could probably use a stoma cloak. And he said, oh, no, she doesn't hunt. And so I thought, well, you didn't get it. This is not for hunting. This is for daily living. So Thyla gets it. Thyla gets it, and so she has a show called Osto Mondays on YouTube, and she is a United Kingdom woman, and so she has a wonderful accent, and she's very cute as well. And so she presents things in a wonderful way, and she actually saw our product, bought one, and said, hey, do you guys want a video? And we said, yeah. So this is the video.
Adjust it to fit around your bag, and then once it's up, you just fold it back again, and then it's just nice and neat and tucked away, and it's done.
Sorry about the volume. So,
adjust it to...
I'm sorry. Oops, how do I advance it now? There we go. So, does it work? Well, we have 3 studies or 3 situations going on right now that we think are proofs for us. And just to run through them quickly, there's more about each one of these. Right? These bomb-sniffing dogs are going to blow you away. They're the best part of my presentation. We're doing a veteran study in Ann Arbor, Michigan right now on veterans returning from Iraq that have ostomies. And we're just giving them bags to see if if they can, that we can show a quality of life improvement. And then we have a lot of testimonies. So this is Dr. Fabio Grizzi in Italy. My partner ran into at the American Urologic Association, and he has a dog named Lou that is trained to smell urine or detect something from prostate cancer in patients with with prostate cancer in their urine. So there's some volatile substance that comes out of the urine in patients with prostate cancer these dogs can find. And so this is just showing this dog. Each one of these containers has a fluid in it, and the dog found the one with prostate cancer. So this one, again, these containers each have urine specimens in them, and that third specimen, again, has urine from a prostate cancer patient. And the dog, we've covered it now with a stoma cloak material. And the dog doesn't detect it. They take them around 2 or 3 times, and it's a wonderful, we don't know exactly what the substance is, and they were happy to have our thing because they think that the stoma cloak material that was in that container is masking something or is absorbing something, but it's going to help them in the process of identifying what that substance is. So I'm not going to go over these testimonies with you, but I want to just tell you that we have loads of testimony about how wonderful this thing is, and I have 2 specific stories, and again, I have 3 pages of these testimonies just on these slides, but I had a 16-year-old that had a colostomy for Crohn's disease, send us a letter back, actually his mother sent it, and he was trying to go to the prom, he had a new colostomy, couldn't figure out how to get the gumption up to ask a girl to date him, and his mother got one of our stoma cloaks online, bought it, he put it on, and he wouldn't give it up, and he asked a girl and went to the dance. And so we have so many stories like that that are just incredible because they're allowing mainstreaming of patients. They're allowing people with ostomies with a disability of sorts to be mainstreamed. This, if it's any evidence, if popularity is any evidence of success, this is our sales line over the last 2 years, and we see a nice trend upward. And so we have patient satisfaction, comfort, health, decreased overall cost of bag use, because if you use this appliance, this stoma cover over the appliance, the bag lasts longer, so patients can, especially people on fixed income that only get 4 bags a month, which is what some insurance company decided for them, then they can make them last longer. So in summary, the irony of me, a urologist, contracting an illness that I was used to taking care of is the twisted irony of this, that I got prostate cancer and had to have therapy, surgery that I do for other patients. I found myself in a position of need. My community arose to the issues, and we're touching many lives. So we made lemonade from lemons. Thank you.